Okay. Hello, everyone. Good afternoon. I hope in these COVID days, in these terrible times we are living in, you all are looking after yourself very well and taking all the precautions to make sure that you and your near and dear ones don't get infected. Now, today we are going to talk on laparoscopic and hysteroscopic surgeries in infertility. Now, this is actually a very long topic, but I'm trying to keep it as simple as possible for uh, non-medical people to understand it well. Now, to begin with, what I'll do is I'll give you a general background about what endoscopic surgery is, what laparoscopic surgery, what hysteroscopic surgery is. And then I'll take you into the various conditions, briefly touching upon various situations, various clinical conditions where these two surgical procedures do have a role to play and can improve significantly the chances of conceiving of infertile couple. Now, traditionally, historically, we all know that abdominal surgeries, when you talk of, it used to be by open method, which means you have a big cut on your tummy, either on a vertical up and down way or a horizontal scar. But these days meaning last more than 2 decades ago, endoscopic surgery, which is laparoscopic surgery, has come big time. In laparoscopic surgery, what we do is a small camera goes from your belly button, mostly what we call umbilicus. A camera goes from there, and 2 or 3 additional small 5mm ports, which is small 5mm holes, are made in your abdomen, in your tummy, and instruments are introduced through that through those tiny holes to carry out major procedures and minor procedures both, depending upon what the clinical condition we are dealing with is. Most of the times, laparoscopic surgery, which we do, we discharge home women on the same day or within 24 hours. So it's hardly ever it happens that patients have to stay in the hospital for more than a day. Mostly 24-hour discharge is what we have, despite the fact that we do quite advanced, extensive, and advanced laparoscopic surgeries. The benefit which laparoscopic surgery gives over traditional open method is that women who undergo this laparoscopic surgery, they recover very quickly after surgery. They do have very less pain after the surgery. Most working women can join work within a couple of days, and the need for painkiller medications is far less compared to open surgery. Likewise, the blood loss which also happens during open surgeries is far more compared to laparoscopic surgery. So laparoscopic surgery is associated with less blood loss. And in technical terms, medical terms, we call adhesions, post-operative adhesions, which means after the surgery, like you see scar on anywhere when you have a cut on the skin, you have a scar on that part of the body. Likewise, when you do surgery inside in the pelvic cavity, in the abdomen, inside the tummy, the area where you do surgery, you'll have adhesions, which means tissues tend to get stuck. And most of the times, the anatomy, which means naturally the organs have a particular relationship with each other, and that particular relationship is disturbed when you have a surgery done. When you compare that disturbance or distortion of the anatomy of the normal structures or organs which you have, that is far more disturbed in open surgeries compared to laparoscopic surgery. So laparoscopic surgery does give you that benefit also of less post-operative adhesions. Therefore, it gives you less long-term problems compared to open surgery. This about just a general background about what happens in laparoscopic surgery. When you talk of hysteroscopic surgery, which is also another way of calling endoscopic surgery, there a camera actually is sent inside the uterus. It is sent inside the womb of the woman, and we have a look inside the cavity of the uterus to see if there is any abnormality which we see, which is something not normal. And those kind of conditions usually would give problem in the form of infertility, or they can give mainly bleeding problems, or in some women it can also give recurrent abortions, which means the woman may get pregnant, but she'll keep aborting every subsequent pregnancy. So this hysteroscopic procedure is relatively, compared to laparoscopic surgery, it has less complications or less potential for complications. And that can be most of the times performed as day case procedure again. In fact, these days, outpatient procedures also are done, which means you don't have to get admitted, you don't need analgesia, you don't need any anesthesia for that. Anesthesia you don't need, and you may need a little bit of analgesia, which is pain relief after the surgery. So these are two main endoscopic procedures in gynecology: laparoscopy and hysteroscopy. So after having given you this general background about these two procedures, let's now talk about infertility. Now, I don't think I need to mention to the people here what infertility is, because most of us are well aware of this particular terminology. Infertility is a condition where a couple, after having tried for pregnancy for at least a year, could be 18 months, but at least a year, if they have had tried for pregnancy and they have been unable to achieve pregnancy, that couple is called infertile couple. I'm saying couple because that is what infertility is about. There will be many occasions, could be up to 40% of the times, there can be a male factor, which means everything in the woman is absolutely normal, but there can be problem in the male partner, because of which infertility happens. And there are 40% of the times there could be problem in women, which can lead to infertility. Now, after having investigated both the couple, both the partners, if there is still infertility, then that can be called as unexplained infertility, which will form around 20% of the population. So now what we are going to talk in this particular session here is the role of endoscopic procedures, which is what I have just explained, laparoscopy and hysteroscopy in infertility. So what are the conditions where you can have infertility that can be corrected by one of these two methods? Now, let's talk about laparoscopy. One of the most common conditions which most women, especially in India, do have is polycystic ovarian syndrome. PCOS is what most of the women are aware of. PCO, polycystic ovaries, is what is very common. In infertility clinics, if you see, it will form a large chunk of women. In different studies, they have shown even 40% of women coming to infertility clinic may have polycystic ovaries. This condition is typically it presents with less amount of bleeding during periods, less number of periods in a year. So it will be very infrequent. They can get periods every 1.5 months, 2 months, many times 3 months, or most of the times even they can get periods only when given medication. So they don't have spontaneous or periods occurring spontaneously, naturally. So many times they need some hormonal medication or treatment to get the periods. So these women typically have what we call in medical terms anovulation, which means they fail to produce eggs every cycle. So they don't really release egg in every month. So that reduces the chances of getting pregnant, because if ovulation is not happening, there is no egg available for getting for conception. So that is where infertility can happen. Now, most of the times this can be corrected by medical methods, and which means by giving medicines it can be corrected. And many women will actually respond to medicines, and they will release egg, and then they can get pregnant. But there will be a large chunk of women who unfortunately don't get ovulation. They don't respond to treatment, and therefore the pregnancy will not be achieved. So these are the women who may need surgical input. So when women have polycystic ovaries and we're trying for pregnancy for around 3 to 4 cycles, maybe, depending upon how the counseling goes, you can try for 3 or 4 cycles, and if pregnancy doesn't happen, then they are someone who can be advised laparoscopic surgery. In laparoscopic surgery for polycystic ovary women, what we do is we do initial survey of the abdomen and the pelvic cavity, which means inside the camera, once it goes inside the tummy, we have a look at all the organs, and specifically focusing on gynecological organs, which includes uterus, tubes, ovaries, and the surrounding area. Now, once we know someone is has polycystic ovary, and she has failed to respond to medical methods, then we do what is called ovarian drilling, in which we use electric current to make holes in the ovaries, in those cysts, to reduce to make some hormonal changes that I can't go into details here in this chat here. But what it essentially does is it increases the chances of ovulation in those women who have this procedure. Now, they can either ovulate spontaneously, which means they can do it themselves every cycle, or they can uh, they need some help. They may need some medications to help ovulate. But the chances of pregnancy go up significantly in the subsequent 1 year following this surgery. So this is something which is really has a proven benefit in women, but in over enthusiasm, what the doctor should not be doing is doing multiple punctures and using multiple currents, which can be counterproductive. Again, that's something which is a very technical thing I won't go into, but a maximum of four drills is what is recommended to make ovaries regulate and ovulate regularly in the subsequent cycles. The benefit of this surgery remains maximum at its peak for around a year after doing the surgery. So the chances are maximum during that year, and most of women who have to get pregnant will get pregnant within the 1 year of having the surgery done. The second condition which I would mention here is about endometriosis. This endometriosis is a condition which, again, if it's advanced, which means it also has ovaries, for example, involved, and the ovary has actually enlarged in size to become a cyst, which in technical terms we call endometrioma. If that has happened, then that can be seen on the scan. But there is a condition called superficial endometriosis, which means it is just about scattered all over in the pelvic area where the genital organs of the woman are. And that can cause a kind of unfriendly atmosphere for pregnancy to happen. And that can lead to infertility. Now, there is no radiological or imaging investigation, which we say imaging, meaning this ultrasound scan, CT scan, MRIs, those kind of imaging is not available for diagnosing or identifying these conditions, unless, as I said, it is advanced, that it involves the ovaries, it involves the bowels, which is the rectum, or the pouch of Douglas, which we call, which is behind the uterus. If those areas are affected badly and it is quite advanced, then that can be picked up on ultrasound scan. But superficial endometriosis, the gold standard, which we say, the way it can be diagnosed is by inserting a laparoscope and having a look for your own eyes. And that is where you know that endometriosis is present. And even if it is mild endometriosis, there is enough evidence for us to know that those mild endometriosis, which is not picked up on any scan or even history of the patient or examination, can actually be seen on laparoscopy. And many times it just needs minor procedure, which we do so laparoscopically, to help these women get pregnant. So that is something which also can be treated with laparoscopy, and infertility can be improved to a significant extent. The other condition is adhesions, which we call adhesions, meaning pelvic adhesions, which means here in this condition, the natural anatomy, which I was saying earlier, the natural relationship of the tubes and the ovaries to each other, tubes and ovaries to the uterus, and generally the pelvis and the intestines, that is altered. That adhesions is bands running between different organs, like curtains. So if they are altering the anatomy of the pelvic organs, that can lead to infertility, and therefore we have to identify that by laparoscopy. Now, these adhesions can be as a result of previous surgery, it can be because of previous infection. Many times the woman may not even have been aware of the fact that she had some pelvic infection. Her body might have recovered of it, not knowing that she had infection in the past. In India particularly, tuberculosis is very common, and we still see women who have tuberculosis of pelvic organs, which can be picked up on laparoscopy, meaning we have to do some tests, we have to take some samples out and send it to the lab to find out whether there is tuberculosis. But visual impression when we do laparoscopy can give us an idea whether that person has or could have tuberculosis as the cause for infertility. And especially these adhesions, which I said, if they are there, then surgically we have the expertise to break those adhesions and bring or restore the normal anatomy. And once we restore normal anatomy, in most of the occasions, pregnancy may be achieved. Although these adhesions, primarily the outcome will depend upon what the underlying cause was, which means why did it happen in the first place. So depending on that, because there are certain conditions like chlamydia infection, which is not very common here as compared to that in the Western world, those conditions can lead to permanent infertility as well. So most of the women have quite a significant damage done to the tubes and including the pelvic cavity, where pregnancy becomes impossible to achieve naturally, they have to go for artificial methods, which is assisted reproduction techniques, which again is beyond the scope of this talk. Then the other common condition which we come across is fibroids, and the fibroids mainly there are many couples who come to me and say, we have been diagnosed with fibroids and they have infertility. Can that cause infertility? Now, there are many pregnant women at the same time, on the other hand, who are pregnant and they come back saying that I'm pregnant and I have fibroid. So essentially what I'm talking of, there's a group of women who are pregnant and they have fibroid. There's a group of women who are not able to get pregnant and they have fibroid. So essentially, fibroids don't automatically mean that you have infertility. You will have infertility. The management of fibroid will depend upon the location of fibroid, the number of fibroids, and the size of fibroids. These are the three crucial things which will determine whether it is going to cause infertility or it can cause infertility, and whether surgical treatment of that fibroid is going to really help the couple, help the woman. Now, it's a long topic in itself. I can probably speak for hours on fibroids, but as far as this talk is concerned, all I would say is not all fibroids would cause infertility, but yes, in couples who are trying for pregnancy and all other tests are normal in the woman, in the male partner, and the fibroid is the only identifiable factor, and that too, especially if it is in the cavity of the uterus or it is distorting the shape of the uterus or the uterine cavity, which we say, then that can actually cause infertility. So removing those fibroids will definitely be helpful, and we've got a lot of women who we did fibroid surgery upon, and they have got successfully pregnant and have achieved pregnancy without any help. So yes, fibroids are something which can be treated by laparoscopic method, and that will give you a positive outcome in most situations. Although all these results which I'm talking about are not guaranteed, but they do enhance or increase your chances of getting pregnant after the surgery. Then the next one in the list I would say is adnexal masses, which means the cysts in the ovary. Ovaries are the organs which produce eggs and the hormones in the woman, but they're very crucial for achieving pregnancy, obviously, because they do produce eggs. Now, if there is ovarian cyst, I earlier touched upon endometrioma, which is a condition where endometriosis is on the ovary, and the ovary can be increased in size. That is a very well established known cause for infertility. Now, when you have that kind of condition, medical treatment is probably not going to be as helpful. So most of us would say that it is, if you want to get pregnant and if you have endometrioma, then surgical method is probably the first thing you should go for, because that will definitely not only correct the anatomical problem, because you're not expecting only the ovary to be sorted out. There will be a lot of adhesions which will have altered the anatomy. It may also affect the tubes, and the tubes may get distended or swollen. So that kind of picture is most often seen in severe endometriosis. That will at least give you an answer whether irreversible damage has been done, which means are the organs or the anatomy distorted to the extent that normal or natural pregnancy is impossible. At least you get that answer and then you move on. Or was it rectifiable? Could be rectified, and are the chances better than what it was before the surgery? So these are the answers which you would get when you have laparoscopic surgery in endometriosis. Earlier also I mentioned about superficial endometriosis, which means that endometriosis which is not seen on any imaging, that can be seen very well and very clearly on laparoscopy, and treatment or excising those endometriotic lesions, meaning you take it out, or some surgeons who prefer using some electric current and burning those lesions inside. So that also increases your chances. But where possible, it is better to remove that endometriosis out, so that the chances of recurrence, which means chances of it coming back again, also are minimized. Then another very common condition which we see is called tubal block, which means either one or both of the tubes may be blocked. And when you have a tubal block, it is not possible for women to get pregnant, because open tubes are essential, are crucial for the sperm to travel the tube and fertilize the egg. So wherever the tubes are blocked, natural pregnancy is impossible and out of question. Therefore, many consultants these days who are seeing infertile women would actually refer for laparoscopic surgery, or at least one X-ray called hysterosalpingogram, which is HSG, for for identifying whether the tubes are open. The advantage of doing the HSG, which is X-ray, to identify whether tubes are open, is that obviously you are cutting down on your surgical risk, which includes the risk of anesthesia, risk of surgery itself, and at the same time you are also saving on the resources. But the but on the other hand, what you will be doing also is you are not only identifying the tubes whether it is open or not, you will also be able to identify whether the cavity of the uterus is normal. Now, the disadvantage of doing HSG, why is it not that popular, is because it will not tell you whether everything else outside is normal, meaning it will only tell you whether the uterine cavity looks normal and whether the tubes are open. But that's it. After that, there's no further information. It can give you whether the cavity is normal or not, but it will not tell you about these endometriotic lesions, which I said, or the adhesions, which I said, or superficial endometriosis, which I said. These are the conditions which can't be picked up or which can't be identified by HSG. So many times it becomes a wasteful exercise because you feel that the tubes are open and you carry on trying for pregnancy, eventually ending up with laparoscopy at some point because there are other conditions which the HSG hasn't or could not pick up on. Nevertheless, having said that, it is a helpful investigation, and it is obviously far less expensive than laparoscopic surgery. Now let's quickly talk about hysteroscopy, and then I'll take some questions from you. Hysteroscopy, as I said, is a camera check inside the cavity of the uterus, and we identify whether there is any problem inside or it all looks normal. Now, the hysteroscope will identify whether there is any septum. Septum meaning if it is a developmental problem, you will see uterine cavity which is divided into two halves, which means it is divided by something like a partition. If you put in a room, you divide the room with that partition into two halves. That is what essentially will happen when you have a uterine septum, which means the septum is actually causing the uterine cavity to be divided into two halves. Now, the severity of or the length of this septum will further determine as to how severe the situation is. If it's just a little septum which is just at the top of the uterus, it will not cause any infertility, it will not cause any pregnancy problem, and it can carry on. But if the septum is quite large and it's reaching the whole of uterine cavity or even beyond, then it can cause infertility, or even in women who do get pregnant, it may cause what is called recurrent abortion, which means they get pregnant, but the pregnancy doesn't carry beyond a certain stage because that septum is not allowing the pregnancy to grow, or the blood supply is impacted if the pregnancy is implanted on that septum. Likewise, earlier I mentioned about the adhesions inside the pelvic cavity. Women can also have adhesions inside the uterine cavity, meaning the uterus cavity, instead of remaining open, it's all closed because of the bands which run from between the uterine walls. If that happens, obviously that also is going to cause problem. These women may present with less periods, less amount of blood loss during periods, and also infertility. So these are the conditions which can be identified and treated at the same time by hysteroscopic procedure, wherein we introduce the camera in the uterus and cut these adhesions or cut these bands. There's always a risk of those coming back, but that we can talk at the time of consultation. Someone who has this, you can talk to your doctor and see how best you can avoid those adhesions forming again. Similarly, I left that topic halfway there about tubal block because it is actually treated by hysteroscopic method, especially what we call if it is proximal block, meaning if the block is closer to the uterus and you know that they are not open, then we have some special devices which we introduce through the hysteroscope, through that camera, and we try to open. It is like opening a blocked drain, for example. If your drain is blocked, you use some smaller, thinner instrument to open that drain block. Although I'm making it look simple, it's not that simple to do it in a patient. Opening those tubes, they're very tiny holes. You have to introduce a very tiny, thin instrument or a wire through it and then open the tubes. The success rate of the tubal block is almost 90% in our experience. If we do it in 10 women, 8 to 9 out of them will get pregnant, if it is the only and the sole factor which is responsible for infertility. So tubal block these days can be very successfully treated by hysteroscopic tubal cannulation, and they are day case procedures, which means you come in the morning and go home the same day later in a few hours time. Very rarely we have to keep the woman in the hospital for over a night. Otherwise they go home the same day. After talking about the tubal block, the other thing which can be responsible for infertility and can be identified and treated by hysteroscopic method is uterine polyps or fibroids. If there is a irregularity in the uterine cavity because of a protrusion which is fibroid, or which is because of a swelling of tissue, swelling of the tissue of the uterus, which forms a polyp, that can also cause infertility. Therefore, many of the infertility consultants or specialists will also these days advise doing a hysteroscopic procedure prior to doing IVF, that is in vitro fertilization, just to make sure that the uterine cavity is normal and doesn't have any problems which can lead to infertility. So these are the conditions which can cause infertility and can be identified by hysteroscopic method, and it can be treated. Again, removing these fibroids or polyps can significantly improve your chances of getting pregnant. Then if visual look, if we feel that it doesn't look normal and there is some risk of infection which we suspect, or if someone had past infection, if that is what we're suspecting women may have, then we take some biopsies from the uterine cavity. Not biopsy really, but it's some tissues which we collect, and we send it off for examining whether there is any evidence of infection, specifically and particularly tuberculosis infection, because we know that tuberculosis is common in this part of the world, and second, it can cause infertility. So these are the things which we do at hysteroscopic examination or hysteroscopic procedure. These procedures, as I said earlier, we can do it as day case, or most of the times these are even done as outpatient procedures without any need for anesthesia. So the recovery is very quick. But unfortunately, there will be some women who will have significant pain because of hysteroscopy. And if that happens, clearly you have to identify those women, you have to make them comfortable, give them pain relief. And if necessary, we may also have to use anesthesia to make sure that they're comfortable and they don't get significant pain. So this is an overall view of laparoscopy and hysteroscopy and their role in infertility treatment, identifying as well as treating. Most of the times, I would say more than 99% of the times, these treatment can be done in one sitting, which means once we do this operation, it can be most of the procedures which can be sorted will be done at the same sitting. But there will be some situations where the procedure may have to be repeated, and those are rare, but that can happen. And this can happen especially in conditions where women have severe endometriosis, which is what I touched upon earlier. If the intestine is significantly or very severely impacted with the disease, it is affected by the disease, then it can cause adhesion with the uterus, with the ovaries, and if there is thought to be a significant risk of injury to the bowel, then your surgeon may decide to not go ahead with the whole procedure at the same time, but may call you back at a later date with adequate preparation and maybe with a surgical backup, meaning a surgeon, a bowel surgeon, intestine surgeon who will be there with him to deal with any complications that may happen. I wouldn't say complications because many times these are actually deliberately to remove the disease. We may have to actually cut open the bowel, remove the disease, and then suture it back. There are various stages of that and various ways of doing it. I'm putting it in layman terms, but I'm just trying to tell you the point which I'm driving is that if the bowel, if the intestines are involved with endometriosis, then there is a significant risk that your intestine may be injured, either deliberately or opened, or can be accidentally injured. And in those situations, you have to be in an advanced center, and that will be usually by a combined procedure, wherein the bowel surgeon, the gastrointestinal surgeons will do the bowel surgery, and the gynecologist will do laparoscopic clearance of endometriosis from the ovaries and from the surface of the uterus which is there. So I think this is the overall gist of the talk. If there's anything you want to ask, I'll just touch upon one more thing here, and that is about laparoscopic cervical cerclages, which we're doing. It is not strictly to do with infertility, but it is to do with unsuccessful in getting pregnancy to a stage where baby can go home. And that is because the cervix, that is the entrance to the uterus, the cervix is not strong enough to hold the pregnancy, and that typically after 12 to 14 weeks, up to 24 weeks of pregnancy, the pregnancy can be aborted. It just comes out without the woman having any significant pains. If that happens, that's called cervical weakness or cervical incompetence. That is the condition where many women do have, and many centers, many hospitals, many of gynecologists do what we call transvaginal cerclage, which means they insert a tape, a suture material around the cervix uh, transvaginally. But what we also do in those women who don't respond, or those who are unsuccessful in having a successful pregnancy, meaning having a pregnancy going beyond, say, 36, 37 weeks and taking baby home, or even 32 weeks, depending upon where you're working. Uh, we are inserting laparoscopic cervical cerclages, which means through laparoscope from above. I insert the tape around the cervix, and the success rate for that, in our experience, is 100% once the pregnancy goes beyond first trimester, which means once you have crossed 12 weeks of pregnancy, then all those cerclages which we have inserted have gone beyond pregnancy. This is interval cerclages I'm talking about, which means the cerclage is inserted when woman is not pregnant. But if we do it in pregnancy, when someone is pregnant and you insert the laparoscopic cerclage, then there's a significant risk of miscarriage happening. And therefore, it is always preferable to insert the cerclage, to put the laparoscopic cerclage when someone is not pregnant, that is between the pregnancies, and not during pregnancy. When you put it during pregnancy, there is significant risk exists of abortion during pregnancy, during the procedure itself, or even after the procedure is done in the subsequent days or weeks. But that depends upon what stage of pregnancy you have put it in and how the surgery was at the end of the procedure. So if you have any questions, please ask. The chat, I think, is live, and our coordinator Naina must be there to help us with those questions. And I hope you got the general gist about what the talk was about and what role endoscopy plays in infertility. Thank you.